So today, it's my pleasure to introduce Dr. Escoffery, a health educator and behavioral scientist with more than 29 years of experience in health promotion, cancer prevention and control, implementation science, and evaluation. 29 years is hard to believe because you look 29. But Dr. Escoffery joins us from the Rollins School of Public Health, where she works as a professor of behavioral science and health education. She has over 200 publications on various topics in health promotion, dissemination, implementation science, and cancer control research, and is also the past president of the Society for Public Health Education, SOPHE. Dr. Escoffery's current research is focused on translating evidence-based interventions related to cancer control and self-management into practice. She's a multiple principal investigator for the Managing Epilepsy Well Network and the principal investigator of the Emory Cancer Prevention and Control Research Network, their CPCRN. Today, we've invited Dr. Escoffery to speak to us about her experience with disseminating evidence-based interventions for cancer and chronic disease. Please join me in welcoming Dr. Escoffery.
Thank you so much, Maria. It's a pleasure to be here to talk to you. I recognize a few faces in the audience, and I'm here to share some of my collective research with some of my research teams on both cancer and chronic disease, scaling up interventions. So I thought I would highlight a couple of different areas, and then feel free to either ask questions as we go along, or if you want to wait to the end. I know we're having a little get together with students after this. I want to make sure we have plenty of time for that. So some of my initial work that I wanted to present are some current work we're doing on program champions and understanding their roles in scaling up evidence-based interventions. Also, some of you might be interested in one side of scaling up evidence-based interventions, program and cultural adaptation. Spend some time talking about Maria and Pat Mullen's collective work on that. And then we'll be talking about some of my work on other chronic diseases, and then just sharing my background to kind of let you have some knowledge base. So first of all, this is a current project that we have just been wrapping up with the Division of Cancer Prevention Control at CDC on their colorectal cancer control program. So program champions have been cited in some of the literature as key to helping with implementation and perhaps sustaining evidence-based interventions. And so champions are described as those who are highly trusted individuals who can actually help stakeholders and the institutions have buy-in to do that work, particularly in my case, a colorectal cancer. Within some of our research, we have found that program champions are important in terms of some of the different tasks that I have put here, generating support, encouraging and motivating teams, and of course, providing their expertise. And so this mixed method study was really trying to get a deeper understanding and elucidating the roles of the champions within the colorectal cancer program. And so this is a national colorectal cancer program awarded by CDC. We were looking at both the grantees, but also the clinics that work underneath the grantees that really increase colonoscopy, FOBT, and other types of kind of prep for cancer screening. And we also did interviews with selected sites and also grantee sites, and also with 3 of their partner health systems. And you could see that this was done around COVID, so it took us a little while to kind of get all of the data collected. And so interestingly, we're just trying to characterize who the champions are. So you can see here that the numbers in the health systems and also the clinics vary, but there were a lot of champions that the health systems identified. In terms of who were the champions, you can see some of the most common categories: quality improvement specialists, QI, physicians, and other types of providers, and also administrators here. There was variety in terms of understanding how the champions were selected. So we asked if they were selected or if they were assigned, did they emerge naturally? So you can see in many of the health systems, they were more likely to be selected or assigned. Training is also important. So most of the health systems, 76% had training, and then in the individual clinics, about 50%. And then turnover, again, 30 to 40%. We kind of know that healthcare entities are facing turnover probably from COVID, but also post-COVID as well. And also some of these are likely public health clinics that have turnover. So some of the things we were looking at were not only champions, but what helps them stay, what helped them be part of the implementation team. So in terms of those that were less likely to have turnover, champions who emerged naturally were those. And then if we look at some of the characteristics of the organizations that help the champions kind of keep on with their work, obviously some things that we would foresee to happen. They had great leadership support. The programs or services they were doing more likely were flexible or had adaptation, and there was higher organizational capacity. In terms of the interviews, what we were trying to do was really describe what were some of the roles of champions. And so these were a little bit of the 8 roles that we were able to find qualitatively that were described in our interview. So some of them make sense. They were the program implementers, they were educators, but then there were a lot of other things that we saw that would help with implementation and sustainability. So definitely they were advocates, they were change maker as described here, making sure that data were there and to be able to understand screening, understand if you needed to do provider feedback, getting those data. As you can see, quality improvement providers, as I said, were some of the key champions. And then some of them mentioned that their champions were actually the source of sustainability, helping with those activities. And so these are just some selected quotes. So in terms of advocates, they're kind of meeting with the frontline staff, having a lot of buy-in and getting providers to be part of it. In terms of a convener, the champion is the go-to person. They are the ones that the clinic staff and leaders are going to as champions and making sure that they're relaying information to folks, and then into their educator roles, making sure that the clinic stays up to date with screening guidelines. So the United States Prevention Task Force changes in terms of screening and things like that, making sure that they know that, yes, we're going to be inviting 45-year-olds for colorectal cancer screening now and giving them options, those types of things. So here are some key takeaways from that work. In terms of who the champion identities were, these are some of the things that we found. As I mentioned, again, a lot of providers, a lot of quality improvement, quality assurance managers. And then we had kind of allied health folks like navigators, coordinators, those types of things. And then we were encouraging some key takeaways with our messages here, making sure that we also get people to think about having champions emerge naturally, kind of self-select. I'm interested in this role because we saw some data that shows that they're more likely to have less turnover. Providing training and making sure that there's organizational kind of capacities and elements to support the champions. So we're really excited about this because there's been a lot of association with champions, but being able to kind of get into some of the details of the champions and their roles in this big national program is kind of really helpful. And hopefully you can read about this work. It's in CDC clearance right now. I'll make sure we'll send it out if you're interested. Some of my work that I want to present next is in the area of trying to get evidence-based interventions out to more communities. And one of the ways that we do that is not to develop evidence-based interventions de novo or from scratch. We actually want to encourage, perhaps for those that have found evidence-based interventions or package programs that work, to consider program adaptation and then also perhaps cultural adaptation. So I'm going to be speaking to some work with that. In terms of program adaptations, we know that we want evidence-based interventions to be uptake in local communities and clinical and social and public health settings. We also know that in a lot of kind of national surveys or practice implementation, that adaptation is happening because we see varying levels of compliance with kind of the implementing as is or doing the program as designed. And so we want to give some guidance in terms of what are the steps that people can uptake in terms of program adaptation and trying to make the implementation a little bit more rigorous and robust. And so this is one adaptation or within the continuum of research translation. A lot of times adaptation will happen obviously after the intervention has already been designed through T1 and T2. And so T3 is where a lot of adaptation happens. For those that kind of need a basic definition of adaptation is trying to have an understanding of the degree of change or modifications that you're making from an original program. And so here are two definitions here. And so this is some work that I did with Maria Fernandez and Pat Mullen as part of their IAM-ADAPT development. And so we were trying to understand how this was happening in the field as they were developing IAM-ADAPT and doing usability and evaluation feedback. So thank you for that collaboration, Maria. So this was our scoping review of trying to understand what was being done in the field. And you could look at this particular citation here if you want more information. Our key questions were what adaptation frameworks were being used, and then what were the steps or processes people were taking in using evidence-based interventions. We use a scoping review methodology, Arskin and O'Malley. You could see others, but this is the one we did, where we identified the research questions, decided on the frameworks we're going to use, being able to extract the data, and we were really interested in what were the frameworks and actually what were the steps, and talked to consultants about what we found. And so we were able to not only look in the published literature, we did find some adaptation frameworks in the gray literature. And so this is one example, and I think there have been a few other works in terms of trying to capture adaptation frameworks, not just and cultural adaptation frameworks. So if you're interested in this area, these are some frameworks that you can find. But what we did was actually try to distill what are the actual processes and steps that people were taking. And so across those frameworks, we came up with 11 steps. And you could see in green or light green, some of the common steps across all of these frameworks. So being able to work with communities and understand the need for adaptation, the need for the program, understanding the intervention. So you have to know what it is that you're applying or implementing before you make changes. Sometimes people are looking at multiple package programs or interventions or strategies. So making sure that after you understand the intervention, you select the strategies. And then there's a whole consultation process. So you might be consulting with experts who might be behavioral scientists, understanding behavioral policy change. You might be actually consulting with the developer of the intervention, consulting with other stakeholders. And then I would say 6 and 7 are part of the adaptation process, deciding what needs to be adapted, adapting the program. Training staff is very important because, again, in terms of being able to have programs developed and delivered with high fidelity, you want to make sure that they're trained, facilitators are trained in engaging people, those types of things. And then, of course, testing the adaptation with evaluation. So within the article, we present all the different frameworks and then the steps. And you can see, again, the more common steps all the way to the last columns were those related to assessing community, understanding the intervention, and then, of course, deciding on what needs to be adapting and making the changes. One of the things that actually Pat just came in said it might be interesting to look at where these frameworks are mapped onto a historical grid. And so what we try to understand is a lot of these frameworks came out of the early work on HIV/AIDS. Not surprising in terms of they had some of the package programs, or they call them the DEBIs, their diffusion of evidence-based program initiative. And then we also provided when the other adaptation work. So you can actually see that adaptation is pretty much only within like the second or third decade of work in this area. And I'll leave you to kind of see some of these more subtasks within these steps, but we thought it would be helpful to kind of share these for the field. So for each of the steps in the article, we present some of the subtasks that people have to do. And so I think that's kind of helpful as beginning guidance for folks in the field. We're still continuing to do some of this work in understanding cultural adaptation, which I think is a special type of adaptation that you could do, particularly as we move into new settings or with populations that might be speaking different languages that have different cultural things. And so Bernal is one of those, in addition to Casaba and others who've done a lot of work in cultural adaptation. So it gets us to think a little bit more about the language, as I have said, the cultural, and the context in whom we're trying to implement these evidence-based interventions. Some of the work in cultural adaptation, one framework is to look at, when you're looking at our package programs or interventions, not to kind of focus on the surface level changes, which is what people often think about, like let's automatically just change the language and that will be it. And I've worked on several cultural adaptation projects. So we want to go a little bit below that. So they call those deep structure changes, really understanding, does the same logic model or mechanism work? Do we have to add other theoretical constructs, maybe to kind of help make folks in our new cultural change, or do we also have to think more about cultural beliefs or other things that we need to add in there? So one of the things we've been doing with some of my doctoral students is trying to understand, what are the domains of culture that people might be making changes in. So we have some areas here, attitudes and beliefs. Again, those are very much part of behavioral science theories. We have language and concepts. We have traditions, again, part of a lot of our boxes in our theories that we want to think about. There might be symbols and metaphors for us to think about that are different in some of our adapted communities. And then, of course, cultural norms or standards. So these are some of the cultural adaptation steps from some of the frameworks that we have found. A lot map onto the ones that I showed of our previous adaptation work. But you'll see that there's a lot of focus on trying to look at cultural aspects and some of the domains that I just presented. And so these are some of the cultural adaptation frameworks that we've been finding more for general public health. There's a whole body that is focused on like psychotherapy and CBT, cognitive behavioral therapies and things like that. We're kind of more focused on the public health realm because that's actually where I sit. So if you're interested in some of these, they're in this particular article. And you'll see from the citation index on the last column, just ones that might be more popular, like people might be citing or using a little bit more. And so one of the ways that some of you who might be familiar with this area have learned about is that adaptations are happening. So Shannon Sturman and her group have worked with the frame and the frame implementation strategies kind of model to be able to really, I think, do something that we haven't done before, trying to get all of us who do adaptations, cultural adaptations, to really document what's happening. What are we actually changing? And so she has come up with this framework to think about, the content, what is modified in the middle. You see what's the nature or why are you making the modification and why are you changing it? Some of the goals of modification. And so this is one of the things that I think is important for the field. And so some of the things that we've been thinking about in terms of our cultural adaptation and extending frame a little bit is, where does culture fit in some of these boxes? So these are some of the ideas that we have in terms of, understanding context. So making sure that, for example, if we're trying to get information to them, get information out, what are their culturally specific radio stations that they listen to, cultural festivals and events that they attend, for instance. So we need to think about the social determinants of health factors that are important to them. Another example, in delivery, who are the people that they're more likely to listen to? Is it a healthcare provider? Maybe not. It could be folks from the faith community, depending on what faith community they have. Or it could be making sure that we have more ethically matched, leaders, recruiters, facilitators, data collectors to be part of our programs when implementing these culturally adapted programs. And then also thinking about training and that type of work. So yes, that does mean sometimes that our surveys or evaluations have to be adapted and actually sometimes transcribed into a lot of different languages when we're doing our EBI's kind of implementation. So it requires a little bit more thoughtfulness in terms of this type of work. And so a kind of more recent initiative in adaptation, I just wanted to put this out there for those who are interested, is a group from the UK that's done a lot of work in adaptation, and they've done their own reviews, kind of mirroring some of the things that Pat, Marie, and I had done in terms of adaptation. And so they have this adaptation guidance that you can definitely look at. So I think there's a lot more work that we could do in adaptation and cultural adaptations. There's been a lot in some research that says that the culturally tailored or adapted programs actually have, or just as efficacious, meaning they have significant outcomes like the original program. But I think to have that knowledge base is helpful to kind of continue to have evaluation, even if they're lighter than the research evaluation of our package programs or evidence-based programs. We can also make sure that we're documenting. I think it'd be interesting to do some content analysis of people using the frame kind of model for documenting changes and what are some of the reasons people are doing this, and particularly adding some of the cultural elements as well. And then with IAM-ADAPT and other things that we have done in terms of helping people in the field use and apply evidence-based interventions, making sure that we continue to do that in practice. And then, there's been some thoughts, particularly David Chambers at the NCI, that we need not only clearinghouse of evidence-based programs or effective programs, but maybe also having the adapted versions or the adaptome concept also available. So for researchers, for people in the community to be able to use these interventions. So these are some of the folks that have been working with me on adaptation over the years. I want to say this is probably our second decade into working on adaptation. Some of the other things that I do is not just cancer focused, although I have a big portfolio in cancer. I also work in chronic disease self-management. I count, obviously cancer was under that. I have some survivorship studies from NCI. This network is something neat. It's a younger research network from the Prevention Research Center called the Managing Epilepsy Well. And I'm going to be sharing a little bit about the network, but also replication of one of our self-management programs in Georgia, which is the work that we're doing. So epilepsy is a neurological disease. It's not as big as cancer. And so if you're interested, Epilepsy Awareness Month is November. There's a lot of activities happening. So this is another, again, translation slides. You can tell that's one of the big areas I work in. And so to really address population health, we need to be able to really move into T3 and T4. Like once these programs get developed, if they're deemed to be successful, if we can kind of develop them and implement them feasibly in a lot of different communities, then we want to make sure that they're into our practice to be able to, again, come down at the bottom and feed back into population health. So this work is under the CDC Epilepsy Program. And so this is their self-management support framework and how actually the MU network came into being. So I was part of the MU network at Emory. I was the PI when it first was developed, but a lot of our work initially was on just understanding, what is going on in terms of epilepsy self-management. Again, it's a kind of more rare chronic disease, and be able to kind of develop self-management programs to support not only the person with epilepsy, but also, some of their caregivers or other people that support them. And so through the years, we have not only been doing initially self-management research, but CDC's mission was to try to get us to develop epilepsy self-management programs, and in the outer side, look at their evaluation, and then look at what the new funding cycle was focused on a little bit more cost evaluation and cost effectiveness, and maybe even cost analysis. So we know how much it is in terms of delivering that program per person. So if other people wanted to uptake the intervention, they can. So the Managing Epilepsy Well Network is across the country. We are a small but mighty group to try to advance epilepsy self-management by not only doing research, but collaborating with national stakeholder like the National Epilepsy Foundation, the Epilepsy Alliance, and disseminating some of our work here. And you'll see some of our partners. A lot of our community work is done, obviously, with Community Advisory Board. We get stakeholder or patient and also provider feedback. And you can see some of our partners here. And I will also acknowledge that Ross, yes, Dr. Chagall is one of our former PIs, but also a collaborating PI now with Arizona on some self-management work. So it's been nice to work with other collaborators in other areas beyond cancer. So these are a few of our self-management programs that have been developed in previous cycles. This cycle, the 2019 to 24, we're disseminating our interventions through other practice settings. And so hopscotch is a memory enhancing intervention or cognitive improvement. A lot of people with epilepsy do not get quality sleep because of seizures and things like that. Also, some of their medications can make them have memory issues and things like that. So there's a reason that cognition is a focus. And then we have other programs that are focused on depression, like SMART and Uplift. And then mindset is focused, I won't even give all of the spiel, but a little bit more on self-management and self-care and working with the medical team on medication adherence and other things outside of the clinic setting. So most of our programs, well, I should say CDC, when we received these fundings, we all developed these programs for adults with epilepsy. Many of them are multiple sessions or sessions that people can, particularly for the technology ones, can do on their own, facilitating knowledge, skills, acquisition. And then we are in the process, we collectively, we have some adaptations happening for Uplift, for example, in Spanish, and then mindset as well. And then a few of our programs are actually exploring young adults, again, through the adaptation process to make sure that they work for these other populations. And so our focus in Georgia has been replicating hopscotch, which was developed from my colleagues in Dartmouth, so kind of in the Northeast. We wanted to see, does this program work with a kind of more diverse patient population? So Atlanta is probably half and half in terms of African American, and then the other half is mostly white, Asians, and other things like that. So we have a more diverse population. So Hopscotch is a self-management program. It's a coach-based program where people with epilepsy get support from a coach one-on-one, again, and it's very flexible on the time. These programs, for many of our new programs, are actually delivered virtually, just because a person with epilepsy, because they had seizures, a lot of times, a lot of states don't allow them to drive within a 6 month or a year of having a seizure episode, particularly when they're blacking out, tonic-clonic, and those types of things. So being able to deliver things over the phone, telephonically, web-based, and things like that actually really support people with epilepsy. Some of the components of hopscotch are over there on the right. I'm not going to read them, but it's a lot based on awareness, helping them figure out memories, enhancing skills and things like that. As I said, it's focused on cognition and also problem-solving therapy, so that if they are running into issues, because if you are highly anxious or depressed, sometimes it might make it hard for you to remember things. And so we're really testing this program and seeing, again, if there's effect on things like cognitive function and quality of life. And so we started this trial in 2021. We had two, Emory and Grady, which is our public hospital system, basically being able to deliver this program. And so we kind of use our community liaisons, the Georgia Epilepsy Foundation, Angels with Epilepsy. I'm on a board with the CEO, is really a support entity that does support groups for people with epilepsy. And we also recruit via community events. And then these are our inclusion criteria. And so we're really focusing on trying to get 100 people. This is our community trial, so there were 50 participants in this group, and we had basically a waitlist control trial. So we wanted to get everybody the program, but folks have to wait in the waitlist group 3 months to actually get the program. And then we're just following them up at 3 and 6 months in addition to the immediate follow-up. These are some of the measures that we're looking at, and a lot of these are common to self-management programs, measures of quality of life. So we have the QALY 31 for people with epilepsy, NeuroQual, which is more for anybody with a neurological disease. We have a measure of depression, a depression measure for medication adherence. And then this AES-MMI is a measure of different self-management domains that we actually developed within the ME network. Ross was part of that work too, and then demographics. And so we're recruiting for both of the community trial and the clinical trial, which are only people within the Emory or Grady healthcare system. And so we're just following them through this whole rubric. In terms of people who are participating, we are getting kind of adults, kind of middle-aged adults in our program. Hopscotch and CDC, we're delighted to see that we are getting kind of diverse patients with epilepsy. And then we do have folks that are 33%, 10%, kind of in that lower income range as well. Seizure types, focal onset and also generalized onset, which are kind of more common for people with epilepsy. Many of them have been diagnosed for a long time. As I said, they're middle age. And then there's still some seizure frequency. 48% reported that they actually had a seizure in the last 30 days. So we are getting people who are in need of these self-management programs. And again, this is still preliminary analysis, but we're being able to show with our two quality of life measure that the hopscotch intervention group versus the waitlist control are increasing in terms of quality of life. And then we'll be doing follow-up measures. We also see some trends that the hopscotch group is reporting doing more self-management behaviors. Again, that's not the main focus, but 3.52 versus 3.42 in the waitlist group. And then the last area that I wanted to spend a little bit time on is one of my areas of focus is on capacity building. In my profession, as Maria said, I was a past president of SOFI, but also one of the things that drew me to public health is not only in evidence-based interventions, but just making sure that we have the workforce and the interest to be able to do what we do. So I'm going to talk about two capacity building initiatives. Some of these are pretty recent. I work as part of the Emory CPCRN with other of the centers in building the Scholars Program, and I'll tell you a little bit about that. And then I've done some recent analysis on the health education governmental workforce as well. So wanting to present some work on that. So the Scholars Program is across the 8 different centers in CPCRN, but we actually have the call for trainees is across the 8 centers and beyond. So we train researchers, practitioners, and students in cancer and implementation science. One of the things we noticed is a lot of the D&I training programs, dissemination and implementation, were always focused on researchers, little less on practitioners and a lot less on students who are wanting to have exposure to this. So this is really the Scholars Program. It is because of our centers are all across the U.S. We actually have this as a virtual kind of, we do in some ways have hybrid events because the CPCRN National Coordinating Center hosts kind of a 1 or 2 time meeting during the year. But most of the modules are online, and we use 2 different curriculums. One of them has been developed by Emory and others in terms of putting public health evidence to action. The other curriculum is from the NCI, modules on dissemination and implementation science. They attend additional webinars. Some of those webinars are focused on like how to do a systematic review, how to get grants in the D&I space, those types of things. And then they have an individual project, or they can work with one of our network-wide work groups, and we have a lot of different work groups. Some on survivorship, we have a health equity work group, lung cancer screening work, LGBTQI work group. So we have a lot of different work groups where they can participate. This is a small program, but we're looking to kind of think how we want to have it evolve in the next cycle of funding, which starts this fall. But our cohorts have been around 15 to 25-ish. And again, we have a variety of different interests. So you can see, again, we have had less practitioners, but we have a lot of students participating in addition to researchers. This is just to show you where the scholars are coming from. And again, we have our network centers that are in the black dots, but then we also have folks who are from affiliate centers from other cancer centers and other things like that across the state. We actually have a few folks internationally from Europe as well. And so this is our Scholars Logic model. We're really trying to increase knowledge and skills, completion of their D&I project, increase dissemination and implementation networking, both within our network and across the network. And you can kind of see in the intermediate box a lot of the things that we're trying to do. And one of the things that we have found that not only are the scholars benefiting from learning about implementation science and cancer, but you will see the second and third box in the intermediate is that the Cancer Network, obviously, through their engagement in our work groups and things like that, are also benefiting. They're getting more things done when we have projects and things like that. So it's definitely a two-way, mutual beneficial kind of program that we have developed. And we've had several evaluations and articles about the Scholar Program if you're interested. And some of you might want to join it in the future. Some of the evaluations we've been doing are related to mixed methods, but mostly we have surveys to kind of get their sense of how the Scholars Program is benefiting them. So on this slide, I present some of the kind of more quantitative evaluation. We did a framework developed by Patak and others at Washington University on D&I competencies, and they have 4 different domains of D&I competencies. So we asked our trainees to kind of rate themselves on beginner all the way to advanced, or kind of 3 ratings across these different domains. And across all 3 cohorts, so some of these are data across all 3 cohorts, we see that they have the biggest changes in practice-based areas of competencies and theory and analysis. I like to see the theory and analysis because you kind of need to understand D&I concepts and D&I theories. And then the practice base is really good because that's where a lot of our CPCRN work goes into, being able to work with stakeholders, engaging the communities. Those are some of the subdomains in that area. So we're really happy to kind of see some of the changes in there. The scholar surveys also say that they're very appreciative of not only the knowledge gains, but all the training resources that they can go back to. 80% of them are still being engaged with the network and also work groups or other network investigators as well. And these are just a few quotes that we have from one of our cycles. We did some in-depth qualitative interviewing. So the first one we kind of like because they're highlighting not only the professional development, but also being able to work with a work group, the health equity work group. And they designed some health equity principles in terms of our engagement with communities doing D&I science and cancer control. And the other one are just helping them to be really conversant and also know how to put together a dissemination and implementation grant proposal. Maria, pay attention, there you are. So we are thankful because a lot of them have mentoring teams or mentoring faculty. So Maria and a lot of our other centers, in addition to Daniela over here, is the co-lead with me. We have some fun activities in terms of getting the scholars engaged in some of the webinars. And this is one of our funny, we have to do all of our stuff virtual, but kind of fun end of the year celebration. So again, another capacity building program. The last thing I'm going to cover before questions and answer is really something that's important to me is making sure that we're training the best and the brightest folks to replace us, not necessarily me as a health educator, because that's really one of the ways I'm trained, but also for public health. And so this was a workforce analysis. This is the second one I've done with Elaine Auld and other. Elaine is actually the previous CEO of SOFI, our professional association. So we wanted to understand what is the role of people like us, health educators, community health educators in the government workforce, describing some of the training needs and principles where we're doing well, what are areas or gaps that our training programs and also their employers can help them with, and then discuss can we look at benefits of having our credentialing, which is the Certified Health Education Specialist, or the CHES, in that last box, certification, which is a little bit above and beyond just doing their master's program or their MPH program. So making sure that they take that exam. So this was a secondary analysis of the public health wins, which is, sorry, too far, the Public Health Workforce Interest and Needs Survey, their acronym. We looked at about 33.4% of the government workforce kind of deem themselves as health educators, and we looked at a lot of different domains. What did they do during COVID? How much are they engaged in their job and job satisfaction? Do they kind of know and are aware of health equity principles and their involvement in social determinants of health work in their community? And then we looked at a lot of demographics as well. And then we did some comparisons of health educator versus other disciplines. And we also did some comparisons of health educators with a CHES credential versus those that were not CHES certified. So we have found that we did the 2017 analysis. I'm presenting mostly on the 2021 analysis, that health educators are more younger in their tenure in a lot of these governmental public health agencies than other fields. Many of them have a bachelor's, about a quarter have public health degrees, which again, that shows you that governmental public health folks don't always necessarily have the highest degree. They're kind of working with a variety of degrees. Our field is mostly female, not surprisingly, and most of them are pretty young, and a fairly diverse workforce as well. In terms of self-reported training needs, so if they reported these training needs, higher percentages means that they have more higher training needs. So health educators are kind of in the orange, darker orange, and other disciplines are in the yellow. And you could see that all of us need more training in budget, change management, systems thinking, policy engagement or policy. That I think that is not surprising in terms of some of those areas. But you could see that health educators had less training needs in things like we train and you guys train folks in, like partnerships and effective communications and things like that. Their bars are a little bit lower. So I think that is a testament to like your School of Public Health and others like ours that are doing these types of training. This slide compares the same training needs with health educators with the CHES certification and those without CHES certification. And you can also see here that the yellow versus the orange, that those without CHES are more likely to report higher training needs. So somewhere along the line, people who are studying for CHES, preparing for CHES, are being trained with that additional certifications are doing a little bit better than those without it. And the other good message, I think, for health educators is around a lot of these health equity competencies and topic areas. So things like general health equity, social determinants of equality, which are more systems level things that we can change or try to improve versus individual social determinants of health, structural racism and environmental justice that health educators, again in the orange, have a lot more awareness and versus other disciplines. And then what are their confidence? The graph on the right side in addressing these issues. Again, we see that health educators overall are more likely to have increased confidence in addressing these issues versus other disciplines. So some of the things that we're noticing is, there are small gaps, but we're trying to fill them in the diversity of the health education governmental workforce. But mental health is a need. This came about some of the questions that the public health wins from the Beaumont Foundation found and also asked about is, only 60% of health educators reported excellent to good mental health compared to 52% of the general workforce. I put some of that towards that health educators were often on the front lines of COVID. They were also more likely to be the case managers, the people doing COVID work, doing outreach to get people in to get vaccinations. So this was around the time of COVID. There needs to be more training in some of the areas that I mentioned, budget and finance, systems thinking, policy, those types of things. In terms of reasons for leaving, I didn't present a lot of those data, but you could actually, the paper is actually coming out soon in General Public Health Management Practice. Our first paper was in health promotion practice. Both times we found that there's a need for more professional development, mentoring. They wanted a lot more career progression. And many of us that are hiring folks know that a lot of the younger generation are asking for this. I don't think it's unique to this particular survey, but they are looking for those growth opportunities. They're looking for jobs that will help them with progression because they want to not stay in there, for retention. They want to be able to advance within that organization, within a job profile, or maybe assume other kind of roles. And then that the nice thing on the last point is that health educators are equipped, I think, to deal with health equity and addressing racism and things in their community more than other public health disciplines. So some of the kind of things that we were thinking about in terms of practice implications is making sure that we recruit and retain health educators. We think about maybe student loan forgiveness. There is loan forgiveness for some public health entities in practice, and we know that they're obviously for nursing and doctors, so for those that want to stay in governmental public health, that might be a way of trying to make sure that folks stay. Mentoring programs might be important as well, making sure that we train on the areas that they're lower areas that they needed more training on, or saying that there's deficit. The third point there is around really thinking about, for all of us, not just from this survey, but thinking about the mental health and the well-being of the people who work around us, because I think that's so different, I think, than the workforce before COVID, in terms of, I think, some of the things we found on this survey. And then making sure that we continue to diversify the health education workforce, and maybe thinking about where we can recruit future health educators, whether they're Hispanic serving organizations or historically Black colleges and university, the HBCUs, those types of things as well. So I covered a lot of things. These are my different research interests. I'm moving into my 4th decade of work. I'm happy to talk to the students afterwards. So I see myself doing definitely cancer prevention and control, lots of things on workforce and capacity building, both for D&I science and outside of D&I science, chronic disease self-management. And then I started my work in health education, health promotion as an evaluator. And then in the 25 to 30 years that implementation science came, I was easily adopted under that, because we can use theory and methods easily. So that's another area that I have. So these, just thinking about my career and some of the things that I found, a lot of the work I do have community advisory board, stakeholder engagement. So, one area that if you're not well versed in is thinking about engagement science, read about it, learn about it, think about ways that you can engage folks in your work. In all of my grants, I have a period of time where I'm doing the focus groups, I'm doing the interviews with not only with patients, sometimes providers, and really learning through their voices. Mentoring, I enjoy working with a lot of different teams, so making sure that you can mentor and advise others. My life has been around a lot of team science. I've been able to engage with a lot of different topics, as you can see, a lot of different research networks, and I've really benefited from that. So I think team science is being recognized a lot more at universities in terms of your contributions to teams. And so I don't have to be the PI of everything, but I can learn about new things and work with teams and multidisciplinary teams and really benefit from that as I work on new grants. And then the other things for those of you who are more junior, these are some things that I feel like throughout my career are really helpful. Seek out the mentors or the leaders that you want to work with. Sometimes saying yes to new opportunities, because I didn't know when I joined Sophie as a student that I would be president one day. So being able to join things and engage and things like that, volunteer with your professional association, learn about things. Collaboration is a mantra that I think you need to have working in public health, not only academic ones, but others. I've worked with a lot of community-based organizations and others, lots of CABs and things like that. And then enjoy the journey. My journey is still continuing. Many of yours is just starting. Just making sure you enjoy the journey, and also the people who are with you along the journey, because all of your paths will have different people. So these are some of my research network, Ross and Maria. So I've dug up some old pictures. This is our Emory Prevention Research Center that I'm part of. Community engagement. This is the Magnolia Walk, which is an epilepsy fundraiser in Georgia. We just had a booth there, so I just 2 weeks ago put my booth there. And one other plug, we are hiring assistant and associate professors at the School of Public Health in our department. So if you have any interest or have any colleagues that might be interested, just let me know. But thank you very much for attending, and I'm happy to answer questions.
I have a question.
Yes.
About all of the work that you do on adaptation, which is honestly where I know you from. So it's nice to meet you in person because, like I was telling you before, we see your name all the time on those reviews that have been really impactful. But Maria and I are working on a project to develop guidance for using hybrid studies and which sort of hybrid study is best suited for your project. And one of the things that we're including is, if you're doing more adaptation and larger adaptations that have big impact on intervention effectiveness, you're probably more towards a type 1. If you're doing smaller adaptations or no adaptation, you're on the other end. But in all of, I don't know all of the frameworks, but definitely IAM-ADAPT has the evaluation step. And a lot of the steps that you outlined have the evaluation step. What are your thoughts on, where the line is for how big an adaptation is that you need to do more rigorous thing? Where does it start to impact effectiveness?
Yeah, I think that's a really good question. I think it might depend on what you're doing the adaptation for, so and also the audience. And so if you are doing a hybrid 1 trial that is funded from a government agency and things like that, where you might want to have a more rigorous evaluation, then you might have a lot more measures and trying to look at a lot of different outcomes, right? Because I think you're trying to make that case for effectiveness, potentially for that funder. So for me, in terms of the practice world, though, I do think about it differently. So if I'm just doing this in terms of scaling out a evidence-based package program, I might actually do more like what I call lighter evaluation. So I might, and we've done this actually in the MU network, we talk about this all the time. We don't need all the measures that we did in the effectiveness trials. What is our one measure of quality of life? What is our one measure of whatever outcomes that you're looking at? So I think to me, that's what we call it in implementation science, the pragmatic side of, just really implementing to understand, did the adaptation work, and things like that. So I think that's where you're going to have to balance the rigor versus the pragmatic, and maybe not having as big of a robust of measurement, and also a robust of mixed methods and different things like that, because on the research side it might require it, but on the practice implementation side, you just want to know if it works on some level of outcomes. I don't know if that's a nice answer to that, but I think it's some of the considerations that you have to make. Good question.
I have a question. Thank you very much for your presentation. While going through, you showed a graph that was comparing CHES certified people with those that are non-CHES certified.
Yes.
My question is, did you do a comparison of maybe levels, like master's level compared to doctoral levels? And would you advise even doctoral level students to go do CHES certification?
Yeah, so that's a really good question. We did not do that analysis, so answer your first question. Some of it is also, for this analysis, this is governmental health educators, so it might be hard to kind of get the different levels within CHES, like master's versus doctoral. But do I advise you in considering the CHES exam? I say yes, if you're in the health promotion field. That exam and just studying for it, just like other, like the GREs, you are kind of building up your competencies. For some people, it might be refreshing things that they may have learned in their professional prep programs, like a school of public health, like the UT Houston one. So you are kind of studying for the different domains that they test under. So assessment, evaluation, implementation, communication, advocacy, a lot of those areas. It's a sit-down exam. You only have to do it once, and it's multiple choice, which I think is the best, meaning that you don't have to, it's not scenario-based, not a lot of open. So I think it's one way of assuring yourself that you have the skills in some of the areas that the test. And then the other benefit, I think, from a professional side of CHES is that just like my husband's a lawyer, continuing legal education or continuing medical education, you need to renew with a certain number over 5 years, you have to accrue up to 75. So you can make the case to yourself or to your employer that you need to have that continuing education. So to me, that is where I'm a lifelong learner. We should all aspire to do that. That's where I think the CHES also helps people, for those that get it, to make sure that you're staying current. You're going to meetings, you're presenting at meetings, you're presenting.
So, I'm part of the CRCCP project here at UTHealth. So we partner, with PhDs here in Texas to increase their cancer screening with colorectal cancer screening rates. One of my questions is we use technical assistance strategies, and one of it is program champions is presented. So my question is, how do you engage, practically, how do you engage, program champions, for instance, if they have other roles, right? Like if they're physicians or like community health workers. I just wonder, if you have any insights on how to, engage them to contribute to
Yeah, so you probably saw from some of my earlier slides that some of the champions were assigned the role, so they kind of knew, maybe not all the 8 roles that came out from our research, but they kind of knew some of the roles that they're going to provide. I think the training aspect is very important too, that that they know what role that if it's in FQHCs or other settings that you want them to be, because in many of the CRCCP programs, they were the ones that could actually get the rates for their clinic or their health system and say to their provider, whether it's the individual provider level or the individual clinic level, this is where your screening rates are. And if you want to increase it incrementally or by 10% in the next 6 months, these are some of the roles. So I think that's where the training comes in. And maybe even thinking about some of the roles that I presented and saying, these are some of the areas that you could work in as champions. Making sure that you have the data, making sure you're convening people, advising them on the latest and greatest, guidelines, whether it's nationally or at the state level. I think some of our champions also, I heard the previous lecture, are trying to do the things about once people get screened, what are the local resources? In Georgia, we also have a cancer disparities, for treatment, but we actually have providers that provide free colonoscopy. So, getting them into the right programs for treatment once they're finding an abnormal things or they're developing polyps and things like that. Yeah.
I think it's related to the last question. So in one of your slides, there was with the champions, there was perceptions of non-fit, right, with the role. That was like one of the barriers or challenges, I think it was. And so is that this scenario where maybe they were hired to do something else and then they're assigned it, and so they have a perception that they don't fit with the CRCCP role specifically, or the champion role in general?
I think it's more the champion role.
Okay.
Because, just from, I think some of our research, people did say that if they self-selected, meaning they want to do some of these roles and tasks, but it's more the fit of the role. Like if they're assigned from the clinic, a lot of times, so the way the grantees work is that they find partnering clinics who want to increase their colorectal screening levels. But as part of the contract, again, this isn't what CDC prescribed, but they actually said you have to identify a champion. So I think that's the comment of, so-and-so physician, you're being assigned this role versus somebody that emerged or was asked.
Yeah.
And that we found that true in our research too. People stayed if they were kind of the naturally emerging champion.
Yeah, I think that this the work that you all are doing in unpacking champions and what does it mean and what are they doing is super important. And I was wondering if you're working on or interested in sort of mapping the mechanisms of action of champions as an implementation strategy. It's something that we recently did with facilitation.
Sure.
And because, that's something that I think could be really important.
Happy to have some conversations about that. But yes, champions are, as you said, an implementation strategy. So a lot of times we know in implementation science, you might have some guidance like implementation strategies, but we don't have the know-how or the how-to, as Maria was just alluding to. It's like, what are the tasks? What's the mechanism? What does that lead to? And I think that's one of the reasons I was excited about doing this first study and wanted to share it right away.
Thanks. I have one other question, totally different topic. So one of the things, this is more on the SOFI side
Sure.
and the health promotion.
Sure.
So, and I'm sure you run into this a lot. So there's a lot of excitement about implementation science, and there has been for many years now, or several years at least. And when you have people from, like, let's say, the clinical practice, or schools that don't necessarily know much about what health promotion is, what I find is that they're sort of jumping to implementation science, and they'll come to us for a consultation, let's say, and they'll say, oh, we want to do this implementation study, and it's really a health promotion study. And so I'm just wondering about if that's something that you experience. So that's one question, and what are your thoughts on that? But also from a field perspective, is SOFI or any other organizations that you know of, like, sort of trying to say, hey, we're here, by the way, it's not all implementation. There is, like, health promotion. I'm just curious about your thoughts on that.
Yeah, so I'll try to answer your second one because I think it relates to the first. So I think a lot of the skills that are part of designing, implementing, evaluating studies are health education skills even before their D&I skills. Does that make sense? Like, we understand how to use theory and things like that. So I do feel like sometimes people don't realize that health educators, and I'm not a card-carrying, for us for coming, I'm not a card-carrying implementation science, meaning I never got trained in implementation science. I do a lot of the work, as people can see. And so I call that my health education foundation, our roots, to be able to do that. So I do feel like SOFI, as a professional organization, is trying to find its place of being able to support kind of like the research and practice of that, not necessarily providing technical assistance around that, but being a place where people can showcase and share kind of the research and practice around that. In terms of, implementation science, technical assistance and things like that, I do think there's a lot of national organization and other, I would say, professional associations that are trying to do that a little bit more, like Society for Implementation Research and Collaboration, so CIRC and others, because it's more just the implementation science community versus SOFI. Yeah, but interesting question. Other questions, or I know it's 10 after, I'm happy to just stay around because I know that's
Yeah. Well, can you join me in thanking Dr. Escoffery